part, which is kind of the philosophy behind what I'm trying to do, which resonates a lot with Tina's part. And then what I took is one example, and I drilled down to give you examples of how we sort of are working through that, and try to reveal in that a bit more the math and the things that we are developing. So what I call the story behind the story, so the things that I try to do, is actually how I can go from individual images to create models of disease and therapy, and also then how we can utilize those models to go back to give information about a particular individual. So one diagram that is core to the whole thing and that resonates with Tina's comment is that I think there are two dimensions of information or knowledge that we want to tap into. One is information that we want to have about a particular patient, so the parameters, the measurements of a particular individual. But we also, and I think we are doing it more and more with AI and with the ability to deal with very large data sets, is to have access to clinical knowledge, so really population type of data. Now, it's quite striking, the parallelism, but I also thought about the car analogy. And the way I have it is by saying what we want to build is a sat-nav system that, in a sense, gives us both the ability to have the GPS positions of the car, so that's kind of the measurements and the accuracy of an individual measurement. But you can have 20 decimals of the GPS coordinates that if I give it to you in a blank map is completely useless. So what you also need to have is good maps, good charts where to position that information. And likewise, you also can have a marvelous map that you have no clue where you are in that map is useless as well. So you need both. And what computational medicine tries to do, which is basically bringing engineering, medicine, computer science, mathematics, is work at these two levels. Is on the one side, do analysis and modeling at the individual level, which is what we have been doing for a long time, but also, and more importantly, getting now into this populational domain or large database domain, because you can only build charts. How we build charts? We take measurements in a grid, and we then create a map, right? So it's essentially being able to do what we do at the individual level, but really at larger scales on really large databases, and on databases which are representative of the population I'm trying to study, so that it doesn't look only to patients which are all similar to each other, which was a point you were making before. So the sort of questions that I'm trying to answer scientifically is what constitutes the normal pattern of anatomy and function, because we are trying to understand disease when we fully don't understand normality, I think. Also how we describe disease across a population. How do you objectively identify subjects which are at risk? What is the optimal strategy for treating a certain type of individual, but also what are the patients that will benefit the most for a particular type of therapy? So all of these questions are interlinked. Now, in order to do that, I think what we need to do is find a way to go from data to what I call wisdom here. So this comes from what is called the DAKY pyramid from information science. So this is a concept from the 60s, but it's a bit adapted to this particular question. And is that we have more data and we process it, and maybe we even build some models. The only thing we are doing is analyzing the past effectively. But what we really, a clinician wants is to take decisions ultimately. And for that, what you need to have is more than past, but you need to have wisdom, which is the validated knowledge. So that knowledge that has been tested across multiple data sets, circumstances, and scenarios, so that you can reliably decide upon the principles that is derived from this wisdom. So doing that requires a number of things. So you need to be able to process and model, as we will come to later on. What sort of decisions we are trying to take? Well, basically answering two types of questions. One is related to risk stratification or connected to diagnosis, but the other one is connected with the best treatment. And in my case, I work primarily with medical devices, as you will see later, so the questions are a bit adapted to that context. Now, how you go from data to wisdom? I contend there are essentially two broad ways to do it. One is you need information processing and knowledge modeling to do that, but you can go either bottom-up, and there you have more phenomenological approaches to modeling, and this is deep learning is one of those, but there are other ways to do it. Statistics is just one of them. So basically that's useful when you have tons of data and you don't have a clue about how things really work. So the best you can do is try to establish associations and inferring relationships between them. But then there is another way, which I think is quite important as well, which is what we call mechanistic models, which is when you do understand the principles, but perhaps you don't have a lot of data necessarily. So here I'm giving, for instance, the Navier-Stokes equations, and then you can infer how the flow in a particular aneurysm is. If you have the geometry and you have the physics and the equations, you can provide that information. Now, there is a risk that we see these two approaches completely independent or unrelated, when actually they are connected to each other. One of the things that I think is quite exciting from a math point of view is whether we can start putting into more phenomenological models, which are more data-driven strategies, more mechanistic knowledge there where we have it. I mean, it's useless, not a smart idea, to try to reconstruct the Navier-Stokes equations by giving a lot of geometries and a lot of flow solutions. We're going to need tons of data to come up to something we know before we start, right? But there are situations where you don't know the laws, and there you can use this technique. So how you actually mix both of them? So something that I think is quite people say is, now with big data and machine learning, we're done. We don't need anything else. I don't believe in that. And a guy called Der Helbing in Zurich made a simple model, which I think tells a lot. One is that data is the processing power, as we know, doubles every 18 months roughly, but the data doubles every 12 months. And I think in your slides, he was saying that it's going to go even faster. More interesting, both of them are exponential laws, more laws, and so on. So there is going to be a moment where we will have more data that we can ever process. But the interesting bit is that what he calls systemic complexity, which is both the complexity of the organ systems and their interactions as a system, but also the complexity of the algorithms we develop that have more and more parameters, actually grows factorially, not exponentially. So we will get very soon to a point where the systems we are trying to study are much bigger in complexity than the data we can ever collect, and that in turn is much bigger than the ability to compute that we have. So what is the way to sort this out is you need to have priors. You need to put some way of regularizing these problems and put knowledge from somewhere. And that's where you need to have mechanistic models. And interesting, there is a recent paper by Andreas Meyer's group where he shows that actually what he calls known operators, which essentially is the concept of putting priors into deep learning, you can actually demonstrate that you can reduce the theoretical bounds of learning rates if you incorporate these learning operators. So this is actually even demonstrated now in the deep learning community. So this is from earlier this year. So what we do in our group is combining knowledge from information from image and signal processing, primarily with modeling knowledge, both AI but also biomechanics type of modeling, and working then closely with people who do acquisition. And we work across a number of areas over the years. But I'm going to focus today on one exemplar, which is the cerebrovascular domain that I want to summarize. So this is what we did over about 10 years, so it's quite extensive, but at the same time give you a sense, even if you just take one problem, how much work there is behind trying to realize that. So what are brain aneurysms? So they are bulges in the vessels that can explode and produce basically a hemorrhagic stroke. People don't really understand completely why they are generated, what makes them grow, and why they rupture. But there are fundamentally two questions. There is always these two questions. One is, who is at risk of rupture when I get them incidentally, and then what I do with them if they are at risk of rupture. Because there is normally a list of possible options. I can do craniotomy and put a clip, so open skull and put a clip. You can go the plumber way, so endovascular, and put a coil, or put a coil and a stent, or put flow diverters. And what you do changes the risk for the patient and also the cost and a number of other things. So this is the second question, is how we deal with them. So the demographics of the disease is a large prevalence of about 5% in the population, so it's quite a lot, but only a few of them, so most of them are silent, only a few of them rupture every year. And the point is, when you know one is ruptured, you need to treat, but if you incidentally find one, what you do is the big question, because there are different treatment options and there is also different types of outcome that you can have. And this is, again, these various points in the pathway that Tina was talking before. Now, the disease is complex. This is what I talk about, complexity. There is a lot of parameters involved, like wall mechanics of the vessel, the tension, the geometry, the perianeurysmal contacts, so what is it around the thrombosis parameters, the hemodynamics, and you name it. So that's what we need to somehow simplify. So what we want ultimately is to develop a system that is like this navigator, in a sense, that provides for a particular patient, what is the risk, the life expectancy, and what are the risks at the time that we do the interventions, but also after the intervention. So obviously there will be always some increased risk when you are treating, but hopefully if you overcome that, you can have a larger life expectancy depending on the type of treatment you do. And that can change, this balance of possibilities can change for every individual. And then once we know we need to treat, what we would like to have is systems that do not only produce the images, but also give us some prediction about, for instance, how the hemodynamics may change as a consequence of the treatment options. So processing, we tend to think, and I think that's another point of coincidence with Tina, is we need to think much bigger than images. I mean, I'm an image analysis person, but you know, the time where you made a career of developing an image analysis algorithm, I think, is over. Probably is the same for any other technique. I think the biggest, in my view, the biggest challenge now is to integrate information and to somehow bring different disciplines together. So in my case, one of the things that I did some years ago is I started to work with people from the biomechanics community, and they came with, you know, ways to solve complex physics equations, but then they had the problem of how to automatically generate all the pre-processing and the post-processing that comes. Because you are given an image, but you need to build, you know, water-type, well-behaved numerical meshes to do, for instance, fluid dynamics or electrophysiology or electromechanics, depending on of the organ. Then you also need to put boundary conditions for that to be resolved, and we'll talk about this later, because that's what it links to physiological monitoring systems. You then throw this to a number crunching machine, but what you get out is actually virtual images now. So again, you have data which has the same structure that images, but is derived from a simulation by a combination of real data and knowledge, in this case of the physics priors. Okay? So now you have these very large databases, or you can have where you have images, and then we can construct relatively easily now with deep learning techniques accurate models of the vasculature. We can detect automatically what the aneurysm, so the area of interest, is. We can then solve physics and get a number of additional parameters like streamlines, wall shear stresses, oscillatory shear index, and we have also a lot of contextual information like omics, genetics, and the clinical history of the patient. And the question is, given this highly heterogeneous vector of data, can you actually derive some conclusion as to, you know, in which way I need to navigate that particular patient? So from an image analysis point of view, one of the challenges I see is scaling up all the things we've done for the last 20, 30 years in, you know, if you look at publications from 20 years ago, you show your algorithm in one phantom and 5 patients, and you could publish it in a good journal. Then you needed to have 30, 40 patients, and now you need to start thinking about big numbers, really, to demonstrate that the techniques are able to deal with data which is heterogeneous, that you don't need to be tweaking for every data set, and so on. So one of the things we've been doing is developing methods for doing that. I'm going to skip specifically how we solve segmentation, which is always a challenge, but we came up with some. I thought it was the least interesting bit to show. Another thing is how you do sizing. So Tina also talked about measurements. So clinicians, for instance, in brain aneurysms, what they do at the moment is the most important parameter they use from the image is something called aspect ratio, which is the depth of the aneurysm over the neck width. And there is a lot of other things that people have provided in the literature, but they're all combinations with repetitions of linear measurements. So we have a very nice 3D technology of imaging, and then we do maximum intensity projections, take 2 linear measurements, do a ratio, and that's what we use from the image. So you need to realize we use very little even from current modalities. But the first thing you need to show is that you can do that you can do the same automatically, and we developed some techniques to extract those parameters. But we had concerns about those parameters because, again, they are linear measurements. So if I show you these 3 aneurysms, they're identically the same dome, but they have different feeding systems. And if you believe that flow has some influence in the rupture of these aneurysms, you need to believe that the flow will be completely different in all 3 of them. So this aspect ratio is exactly the same value for all these 3 scenarios. So what we develop is techniques that, for instance, utilize Cernic moments, which are sort of spherical harmonics in 3D, where you use the amount of image density as a mass density. And what you can show is that if you analyze the aneurysm, the domes, but also the feeding system into that, so you have these constructs rather than the domes alone, you can build models that you can describe up to a given accuracy, this shape, with with these parameters. And the beauty of them is, is that, well, this represents a complete basis from a math point of view, so you can go forward and backwards, and also you can compute invariants from those that allow you to do interesting things. Like, for instance, you can show that this is a metric space, and as a consequence, for instance, if you have aneurysms which are closed in this space, I'm showing only the first three principal components in this space, but if you show them aneurysms which are close, they have similar morphology, while aneurysms that are far apart are very dissimilar between them. So there is a sense of distance, meaning similarity in the shape space as well. And you can show that you can improve sensitivity and specificity using these Cernic moments compared to using aspect ratio. So these are moment invariants and aspect ratios. So what can you use this for? Imagine you bring a new patient and you say, I don't have time to compute fluid dynamics and fancy things, but you have a very large database, so you can query and do hashing from this database and bring aneurysms which are shape-wise similar, okay? And I'm not going to get into that, but for mathematicians, has a bunch of very nice properties. They are invariant to translation, rotation, scaling, and mirror. So left and right have the same values. So you can do very efficient, with a simple Euclidean operation, you can get invariant to all of those things, searches in databases. So this is an example. So we have a database where we bring one aneurysm that is our test case, and we bring all the ones we have in our database rank in terms of similarity. And then you can bring all the meta information, the context, alongside with it. Another thing that you need is when you need to geoposition things when you're trying to analyze a big data set. So for instance, from boundary conditions that you need to set to a particular aneurysm, to, even to do statistics divided by location. So one interesting problem, again, with quite some math behind, is actually how you do automatic labeling of this complex circle of Willis. So this is, it's called circle of Willis. It's the vasculature in our brain where these aneurysms like to appear, mostly in the bifurcations. So it's a smart circular system that we have in our brain that Mother Nature did in order to have certain resilience. So if one of the vessels gets occluded, you get flow from the contralateral side. So the problem is that there is quite a bunch of variants which are all physiologically equivalent. So there are people who have missed one branch, but they're okay. It's no problem. It's just the way we're born. So these are all these dotted branches. So from a math point of view, the way to automatically label that, we cast this into a Bayesian estimation problem, where what we try to have is a graph of all the possible solutions. Then we use some features like, for instance, diameters and angles between the various branches in a 7-tuple, and then these are all the possible options that you have, and you can automatically assign colors in this case as a label to automatically label what vessels is each of them. Because even things like labeling becomes a mess when you need to do this on several thousand cases. Okay. Now, this is nice to do measurements. I skipped also things we've done in terms of dynamic motion of the aneurysms to look at pulsation. So in terms of flow, by the time we were doing this work back in 2012, there were guidelines that came to say that in addition to size and location, which is the thing they were using at that point, and age and health status, it might be reasonable to consider morphological, so 3D shape, and hemodynamics characteristics in assessing risk. And this is an example of a case where guidelines were influenced by the fact that there was research going on that started to show that things might have to be done differently. So I agree with you as well that we don't always want to do what the guidelines, I mean, you need to do that for consistency, but you also have to have mechanisms of exploring things which are a bit out of the mainstream pathway. And since then, there has been quite a lot of work along this direction. Just a few things to show. What we normally do is we assume vessels are metal pipes, so there is no compliance model for some of these simulations. We've shown that you can do that assumption. We can discuss that if you're interested in. But what we've done is a lot of work in terms of sensitivity analysis. So looking at, for instance, if I have a person segmenting the vessels and I use a non-Newtonian model, what happens if I change different rheological models, if I have uncertainty in my boundary conditions and I change the inflow and the outflow slightly from a baseline? So how does everything else change? And what also happens when you have different modelers, so people doing segmentation differently or different algorithms. And one of the main conclusions is that the top first, second, and third parameter in influencing flow is essentially the geometry here. So it's a very much geometry-driven flow, and therefore, we're back to square zero in terms of needing very good segmentation algorithms. We also looked into the influence of imaging modalities. So what happens if you do these models from three-dimensional rotational angiography, which is what you normally do once you have the patient on the operating theater, but also what happens if you do it with CT angiography, which is something you do preoperative, because this has lower resolution, so you also miss some of the smaller vessels. You have wider necks because you're close to the imaging resolution there. So we did studies where we took a number of data sets, and we started looking at, for instance, how various hemodynamic indexes were affected, whether you were doing these 5 patients in verticals with 3D array or with CTA, and with, in most of the cases, with the exception here where the modeler completely changed the outflow of the vessel direction, which of course has a big impact on the flow. The main conclusions were that the structure of the flow, the patterns of the flow didn't change. What was changing was the absolute value. So if you look this in terms of not quantitative variables of flow, like for instance mean velocity at the inlet, but you looked at impingement location and you have categories, you can actually have very good kappa statistics and very good agreement between raters, as opposed of here where you can have 20–30% of error in absolute terms. So we looked into a number of flow parameters, which I'll save you to go in detail, but there are things like flow impingement region, whether it's in the neck, body, dome, or lobulation that you can have. The size of the impingement region is pointy or is a gentle wide flow, or the size of the injet through the neck, is it small and thin or is it large and thick, and the type of complexity of the flow. And so you have, in fact, you have sequences, because this is the flow over the full cardiac cycle, and there is information that comes through the cycle rather than a static value. So these are magnitudes of flow velocity, for instance. And well, there's all kind of patterns. But then you have the problem that also Tina was mentioning, which is now you're giving almost too much data to the patient. So you need to somehow go back and simplify in doing some dimensionality reduction in a way. And for instance, one of the things we found is that if you have large impingement areas, that tends to be usually less risky for rupture than if you have small and pointy flow. Now that might look obvious because it's like you have a jet painting on the back of the aneurysm versus a gentle pressure, but you need to know that this is only a few millimeters of mercury over 100 of millimeters of systemic pressure, so it's not as simple as overpressurizing. One thing that I'm actually quite excited of, one of the works we did, is we said, these models with Cerny moments that we do for look at shape, morphology, and characterize and parameterize that, can we do the same with flow? Because this notion of this flow is complex is a bit subjective. So we came up with an idea, which was to think about the aneurysms as a communication channel. So you have an inlet and an outlet. This is like the input and output, the transmitter and the receiver in a system. And then if you have just a straight tube, every particle you lose in one place comes exactly on the same place if you have laminar flow on the other side, right? So the mutual information, you could argue, is perfect. But if you start then twisting the tube, then this streamlines that start mixing, and if you start putting an aneurysm, that means some of the streamlines get delayed compared to others. So you start having messes there in the information, in the mutual information between input and output. So we came up with something that we call the interlacing complexity index, which effectively deals with the system as a communication channel and using information theory. And we came up with these sort of measures that are actually correlating extremely well with, for instance, the stability of the flow or the instability of the flow. So the value of the index correlates very well with the subjective interpretation of how the flow looks like. So again, this is something where you develop first the intuition through the more subjective variables that clinicians understand, but then you say, can I actually make it more robust mathematically, and then sort of link it back to the intuition to make it more understandable for the users in the end. So once you have these sort of tools, what you can do is say, take databases of geometries or of patient data and then extract all the geometries and start looking at, for instance, which of the flow patterns that you have in a particular location. So these are all terminal aneurysms because they're in a bifurcation at the end. And what we came up is with a classification that there are essentially 3 types of flows in these sort of aneurysms, and that one of them is the most risky one that is associated with rupture most of the time. So again, you give the basis through these techniques, but then the intuition back to the clinician is that's the flow pattern that you need to look at, because that's the dangerous one. Right? Now, I didn't emphasize this a lot, but ourselves and pretty much everybody in the literature does that. You need to put boundary conditions to all the flow simulations. And what we do is either we take them from an atlas of flows, so some healthy volunteer that was measured to death, and you have everything from that guy everywhere in the brain, or you do patient-specific measurements with a cuff, and then you propagate it with a 1D to 3D model that flow to the brain. Now, that thing, even if it looks to be personalized, is completely cheating, because I measure your pressure now, and in half an hour is completely different. I measure after a coffee, it will change. So you need to incorporate somehow the changes in those boundary conditions, that's at least my view, over 24 hours and its variability, and incorporate uncertainty on the boundary conditions as well. But the interesting point is that there are a lot of technology nowadays to measure a lot of relevant physiological variables, and very detailed one-dimensional models that you can use to propagate measurements in a place where it's easy to the place where you do want the measurements. And one of the things we've been doing is developing, again, machine learning algorithms to learn to develop models that allow us to not provide the boundary conditions as a deterministic variable, but actually as a region of uncertainty around that value. And we can have models that we can calibrate. So if we know the sex and the age and the BMI of that patient, we can actually reduce uncertainty to the one we know in the population for that subgroup or that stratified group. So the way I think in the future we're going to do is we are going to not provide you deterministic hemodynamic parameters as an output, but actually also an envelope of uncertainty on those hemodynamic variables, of uncertainty or of physiological variability, depending on how we interpret the input, right? Let's skip this bit. So one of the things that, for instance, was quite interesting is we did some work where we looked into how the hemodynamics was changing in rest and exercise. And then if you know that a patient has a particular lifestyle, you can start weighting these parameters with the different weights depending on how much you assume the person is over a day in rest or is in exercise. And then start generating hemodynamic variables which account somehow, to some extent, for that lifestyle of the individual as well. Okay, so all this is about hemodynamics, but what happens when you start putting devices? Well, devices, we can put intracranial stents, and we know is that depending on the device you put, you can, for the same geometry and different stent designs, you have different outcomes. The operator skills also lead to different outcomes. There are configurations that depend on the patient sometimes and the way you place the device, so the interaction of these two that can lead to also complications. So the way a lot of these patients are planned today, and this is a drawing from one of my Swiss collaborators, said, Daniel, it's called Daniel, so how do you think about how to put a stent? And he said, well, he drew this for me. Imagine that we have a terminal aneurysm. I would want to put a flow diverter this way. I know there is a low resistance distally here, so that will sort of suck blood in, but I will divert most of the flow. I will stagnate the flow within the aneurysm. That will lead to coagulation, and that's the way I'm closing it. And then I say, well, how do you know you need to put it this way and not the other way? Because if I show you the results about depending what you do, I can show you that this is the flow before you do anything, and then this is, for instance, this first row is magnitude of velocity, this is pressure drop, and this is wall shear stresses. So I can show you that depending on the way I put the same stent, you get to completely different hemodynamic parameters. And the point is we don't even know which one of those is the best one either. That's what links back to the previous one about risk, because if we were to know that this pattern is the best of all of them, we know that that's what we want to do, perhaps, right? So then you need to start modeling interventions. So put stents in a particular geometry. Now, there is a big literature from people in biomechanics doing this, but if you take a lot of the very detailed biomechanical models of device release, they take hours. Most of them don't converge on real imaging data. They converge in the tubes where they publish them in Journal of Biomechanics, which is a straight tube or a bended tube, but you put it in a real geometry and they diverge. So you need to come up with methods that are actually compliant with the physics, but at the same time robust as a numerical problem, right? And they're easy to adapt to different types of devices. So we did that, and we validated against finite elements. So this is what we call fast virtual stenting, and this is the finite element version. So you see it's much thinner because it's like a spring model, and this is a proper model with crimping and everything, and the material itself being modeled. And we demonstrated through various experiments that we are with a bounded error compared to those more complex techniques. But it's quite interesting as well how you validate these methods of simulation. And I went to, we published a couple of papers showing this that convinced the biomechanics community, but my interventional neuroradiologists still, this didn't mean anything to them. What they wanted to know, so I said, okay, how can I convince you? So, well, when I put a stent, what I do afterwards is I put a bit of contrast agent that swirls through the vasculature, and if you know a bit the hemodynamics, the fluid dynamics community, they do that with ink. So they inject ink in a flow, and they look at with the swirling patterns. So that's essentially what they do, but with a contrast agent, and they see whether there is residual contrast coming into the vessel or not. Now, that meant for us that what we had to do is create, from the geometries we had, a physical model of the geometry, so basically an acrylic model with 3D printing, for instance. We also had to do a digital replica of the stent by doing micro-CT, and we had to do a virtual release of the virtual device into the CAD model, and a physical release of the physical device into the real model. So we had a real and a physical world. So what you have here is the virtual wall, and this is the physical world. So you don't see the stents in a real world because they have only a few markers that are visible to X-ray, while here is a rendering, so we can see whatever we want. So you see more or less the envelope being similar. And then what we had to do is, for the real and the virtual wall, solve the transport equation. So you solve the fluid dynamics, and then what you do is you solve the transport equation about how a contrast media gets propagated through that flow. The contrast media is X-ray opaque, so you can do a ray casting and generate the virtual angiogram as well. So what you see here is a virtual angiogram roughly in the same position that we got the image. You don't see much, but if I take one point in the middle of the vessel and I trace it over time, you have the time dilution curves that people from X-ray use a lot. And if you forget the blue one, which is at the entrance, is a reference value, the wash-in and wash-out curves of the in vitro aneurysm and the CFD aneurysms are pretty much spot on. Okay? So that means that the way the contrast gets distributed in the virtual world and in the real world are very similar. So now what we have is the possibility to do things like, given a device, you test different types of therapies, and then you look at where you have a sluggish flow, which is usually the area where the clot will come. Now, this is leading slowly into the direction of in silico trials, because now imagine that you have the possibility of collecting. You see that in the literature there is a particular device that tends to fail in a particular type of aneurysms, and you don't really understand why. So what you can do is generate a library of those geometries, go through this virtual implantation, and then study them and try to understand what are the relationships between the various parameters and the outcome in that population. That's the sort of works we started to do some years ago. Now, this is a stent, what you do with coils, which is the other type of devices. These coils are a completely different type of device. What you do is you fill the aneurysm with the idea of reducing flow and eventually to slow down and produce coagulation. Now, you're not going to be planning where to put the coils because it's almost like a random field where you put the coils. But hopefully it will convince you that it's useful to do simulations for this as well. So this is how a coil looks like in a surgical specimen, and when you do histology, these are all the struts that you cut through. So it's a bit of a mess. So we develop a technique based on minimum cost path. Again, the sort of math that are behind, where what we do is we incorporate in this minimum cost path approach, some of the empirics of how these devices go. So the devices kind of do 180 degrees turns. You know, they kind of go through the wall. They have a certain amount of bending they can do for a given material. So you can incorporate all of that, which means that we can then create these models. So each color is a different coil. So the coils come in a certain length and diameter. And one parameter which is important clinically, which is this percentage here, is what is called the packing rate. Is the amount of coil, the metal, over the volume of the aneurysm itself. So 20% means, you know, 20% of the volume is covered with coils. So something we can do through these sort of simulations that you could never do in a pure imaging fashion is the first row represents putting coils up to 20%, 25, 32%. But now I can virtually take them away and put them again. They will come in a slightly different position because this is kind of an stochastic process, and I can then take it away, put them again a third time, and I can do it as many times as I want. So it's like realizations of a random process. What we showed is that as you increase the packing rate, there is a point where actually it doesn't matter anymore the way you put the coils, because you block the flow to a point that putting more coils doesn't add any more flow reduction. Putting less coils will make the flow depend on the way you put them, so it makes it operator dependent. And that is about 25% for this aneurysm. Now, there is a paper in the literature about 10 years before this work, purely based on clinical data, where they show that aneurysms that were either small or large, that remained stable, so they didn't reoccur, had a larger packing rate than the ones that became unstable. So our hypothesis is that if you put too many, you may end up rupturing them by overpressurizing. If you put too few, they will recanalize, which is also bad. So there is an optimal, which is halfway in the middle, but the point is that that is patient-specific. So with these techniques, you could know what is the optimal packing rate for a particular patient, which implies that you reduce cost because you don't put more coils you need. It's like 1,000 pounds each coil, and you put between 6 and 30 in a head, in an aneurysm, depending on the size. So it allows you to optimize cost, which is another thing Tina mentioned. Now, how you validate that? Again, what we found is that the way to validate is to go back, to link back the real and the virtual world. So in this case, we can create multiple implantations in different configurations. We can then do a cross-section of this aneurysm, look at the strut intersection with that plane, and then, for instance, define a core area and a shell around, and then different depth with respect to the neck, and look at the density of the coils as they were distributed there. Now, we had the fortune to work with a group in the US that had also rabbit models where they had exactly the same thing. So we actually built these models on the rabbits. So we could look at the experimental distribution of the coils versus the virtual distribution of the coils. And without getting you into the details, we demonstrated that they are pretty much consistent. So our way of deploying the coils is consistent with experiments, at least in these rabbits. And we also did these virtual angiograms where you can show the curves are pretty stable. We tested these tools as well with clinicians in a number of centers, and we came up with a number of use cases that they liked, and some ways over the years of track how we were improving on those. And in fact, there is a company in Barcelona that is exploiting this technology, which is essentially my former group in Barcelona. One of the things we're working at the moment is that in the end, we don't just do all these simulations to look at how the flow changes. What we want is to produce coagulation. So we need to start modeling now not only the physics, but also the biochemistry. Okay, so how you link, and this is just to show the sort of, these are a couple equations that tells you how the different species in the pathway of clotting link to the hemodynamics in a patient-specific manner. So we've done some experiments where we can show that actually we can get to good predictions of the clot as it's being formed according to experimental data, and simulate and do a prediction about not only where the clot will be formed, but also the quality of the clot. It turns out, from what we found, that if the clot happens too quickly, you don't allow, so what you would like optimally is a clot that grows slowly, so it gets sufficient platelets accumulated and attached to the clot as it grows. If it grows too quickly, the core never gets fully consolidated and can redissolve. Okay? So the last thing I just want to hint is where we are going is in using all this technology, which is for doing patient-specific analysis, to now try to understand devices across population, which was the tenet. And the idea is that the same way that we used in the car industry, we used over the years, simulations and virtual reality and AI. And over 30 years, we've got, from these cars to the Tesla. If I show you how we have grown in terms of medical devices for brain aneurysms in 30 years, it's just a bunch of wires still. So in a sense, you say, come on, we should be doing better, because still we have, after 30 years, 17% complication rate, 2.8 mortality. And we should be able to do the same that the car industry is only 4 times bigger than the medical device in terms of overall volume of market. So there is work going on at the moment in how you could utilize these techniques, how you build virtual simulation spaces where you have anatomies on the one side, physiological conditions, but also device conditions. And here again, for math, is how we model these complex spaces of shapes, of physiology. And then there is never a database that has everything you want, the physiology, the geometry for the same patient. So you need to start thinking about things like copulas, or ways that you can actually link probability distributions from different databases into a single sort of intersection space, if you follow me. And then each of these points becomes a simulation of the one I showed you before, and then you can start looking at developing devices which are optimal for the population, and that are optimal as well in terms of they can operate not depending too much on things that you cannot control, lifestyle, physiological variability, uncertainties, and so on and so forth. Okay? So I'm going to go to the very last slide. Oops. So hopefully, what I show is that if you link imaging and physiology through modeling, you can get, I think, better management of disease and at least have a better grant for doing that. That imaging has to be both descriptive of a population, but also integrate multiple threads of data and be able to be predictive, which you can do through modeling. That translation is not only about developing the technology, but it's also about all these different aspects of validation, where I spent a bit of time trying to explain you how we did it, but even more than that. And that in order to actually get, you can also start thinking in terms of industrial translation, is can we utilize these technologies to help medical device manufacturers to have better systems designed for the benefit of patients, okay? So with that, I'd like to finish.
I'm a radiologist, but I'm not an interventional neuroradiologist, but I have a few practical questions I just wanted to ask you about. How difficult has it been for you to get those follow-up data that you need in real patients? Because, as doctors, as interventional radiologists, we have a tendency, if there is an aneurysm there and it is coilable or central,
just go for it. Yeah.
So I'm wondering how you actually get enough data to see which types of aneurysms actually do rupture. It would seem to me that must be a bit of a difficulty.
Yes, I think you have a very good point. So most of these studies, when we say that an aneurysm ruptured and the other one didn't, is not that we waited on one and the other not. It's aneurysms that rupture and reclose, so there is a bias. There are aneurysms. So there are aneurysms that rupture and the guy dies on the spot, but there are aneurysms that rupture and somehow reclose, and then you have time to bring them to the operating theater. And in some of those cases, and this is the understanding that of what the community does at the moment, is we use the shape post-rupture as the shape. So we know it ruptured, but we are analyzing actually the post-rupture shape. And there are some studies that have shown that the shape doesn't change a lot. Of course, that depends, on the location. There's a lot of caveats on that. But most of these databases are not watchful waiting of patients that we check. We follow them up. There are only a few studies that do that, but they are very difficult from an ethics point of view, as you can imagine. And they're mostly very small aneurysms, so they have other types of bias anyway. This is one point where if we want to build really AI, we need to have databases. Will have to be more than one institution, because these events we are looking at will always be rare. and we will have to somehow collate. That's why standardization that Tina was also mentioning is so important. I don't believe that for doing good AI in the future, our limit at the moment is the algorithms primarily. I think it's mostly the access to data.
Can I ask just one other thing quickly, and that was you mentioned, I mean, I haven't read the original paper, obviously, but you mentioned the rabbit work, rabbit models. How do they create aneurysms in a rabbit? How do you find rabbits with aneurysms?
So I'm not an expert on that experimental bit, but basically what I understand they do is there are some things called elastas. There's some substances that you can put on the endothelium that effectively weaken the endothelial wall, and then it starts ballooning. And in some other cases, they do it surgically as well. But there are normal rabbits that they are treated to create, and there are models of aneurysms that have been published and are reproducible and so on.
You're kind of assuming that the actual dynamics and physiology of those aneurysms, which have been artificially created, is the same as those that we're seeing in humans. I'm not saying they're not. I mean, I have no idea.
Well, for our problem, probably is not a big problem, because what we are looking is just the geometry and how the stents were put. That we are just looking at distribution of coils. But these guys developed the models for understanding the growth process, and I would agree with you that there are assumptions.
The wall is going to be different. I mean, the actual constitution of the wall, and therefore that might affect the likelihood of rupture, the amount of, I don't know, elastin or knee thickness of medial, or the, I don't know, post-surgical fibrosis or whatever it might be.
Most of these models, their main goal is, not that we use it for that purpose, but the guys, we reuse data that they had for other studies, was primarily to look at what produces growth in aneurysms. And, yeah.
Yeah, it's actually just building on her first question and also what she asked you before, one is how to get this data, and every institution said, we don't have enough in our own institution, we need to collaborate together, But on the other hand, if there are a lot of variations like in local policies and things like that, what we find is image data getting like different CTA and MR and so on, that's not the complicated part. But when you have this multimodal data and especially different practices and so on, then even if you get data from different institutions, it's so hard to compare. So would be great. I mean, at some point we need to think about not only standardization, but also from a data format data type perspective, but also how are you comparing apples to apples when you're using cohort population data if the practices were different, So that's also another.
Yeah, just to make your point even a bit more complicated to answer, so I'm not going to be able to answer that anyway, but a lot of the data we use is not clinically routine data. I mean, like some of the physiological measurements are extra protocols which are ethically approved and everything, but it's not things you use for diagnostics today. And so that data will not be available.
Yeah.
So you need for validating models. And the other thing is that in some cases, even if you would have the harmonization of a lot of hospitals in the world, don't forget, this has a bias. These are people who walk through the doors of a hospital to start with. And you want to model the population, not just the guys who went through the hospital. So there is all kind of issues. I agree with you.
Okay, well, let's stop there. But, thanks again for your time.